My name is Rashmi Halker Singh, and I'm the Deputy Editor of Headache. It's my pleasure today to be joined by Dr. Jennifer Robblee, who's the author of a recent publication entitled A Survey Study of Headache Specialist Comfort with Triptan Contraindications. Welcome, Dr. Robblee.
Well, hello, and thank you so much for having me. I'm very excited to be here.
So this is a really interesting study. Can you tell us about your project?
Yes, so I was just interested, and it was one of those things that I wanted to dabble in because we have all these refractory patients, and we get to the point where, we're a little nervous to try things because there's so many contraindications listed for triptans, and even things that aren't listed that we still try not to do in the setting of. And for the patients where I'm struggling to find something, I'm always wondering, can I use the triptan? What are my colleagues doing? And knowing that there's not a lot of research out there. So that's where this kind of came from, was just starting the discussion, because there wasn't much in the literature when I was trying to garner, like, can I do this? Is it okay to? So I was able to get 148 people to actually respond to the survey, and all of them were AHS members. So I didn't delve more into the specifics about them because I actually wanted to go through 10 different circumstances. So I want to try to keep the survey short without too much epidemiology in it. But
So
the
you
big things that I
surveyed
was
clinicians, right? You surveyed AHS members.
yeah, exactly. Yeah. So the things that they were being asked was to comment on their on their comfort with the safety of using triptans in 10 different scenarios. And it was based on a Likert scale. So from always down to never. And then I also added a category for not applicable, just in case they'd never come across the situation. So for instance, we talked about stroke. So the question was specific stroke and TIA, patients with hemiplegic migraine, those with uncontrolled hypertension, those who have venous thromboembolism. And in that case, I did specify if they were already on an anticoagulant, so they had a previous history, not if they were in the middle of it. Patients who had reversible cerebral vasoconstriction syndrome, those who had a prolonged aura or do get prolonged auras that last greater than 24 hours, cerebral aneurysms, dissection of the carotid or the vertebral artery, pregnancy, and then just those who are age greater than 65. So that just itself being the circumstance.
So, this is a really interesting study because there are some absolute contraindications for triptan use, but I find myself in these situations frequently as well, just like you, where I'm like, I don't know if I can give this patient triptan or not. And like you, I'm like messaging my colleagues, like,
do you guys do this?
Right. So what did you find? Were you surprised by your results at all?
I kind of was. I mean, there were some things that were not surprising. So for instance, stroke, a good number of people were not comfortable with that. RCVS, again, a lot of people weren't comfortable with it. But surprisingly, there was a decent number of people not comfortable with hypertension, and I didn't really specify what uncontrolled hypertension was. And technically, the definition of that is 140/90. I personally am okay using a triptan in that circumstance, but we had a good number that were not. And then pregnancy actually had a decent amount of people that were not comfortable, which was very much surprising to me, especially where we do have so many registries that are now showing that pregnancy does actually look pretty safe. The risk of, major malformations are pretty similar to the general population. So that was definitely kind of interesting. People were actually pretty comfortable using it in the setting of venous thromboembolism if they're on an anticoagulant. And that was one area where I've always struggled is, if they have a past VTE event, they're anticoagulated. It is something, vascular related. And so I've always kind of been uncertain what my colleagues do there. So it was interesting to see that actually, not everyone, but a good number of them actually were pretty comfortable. And then just alone age over 65, people were pretty comfortable with that. There's huge variation in opinions though for things like the hemiplegic migraine, prolonged aura, dissection, aneurysm. Every single category on the Likert scale had a decent number.
Obviously, expert opinion is not high levels of evidence when it comes to, right? So, but I still think it's interesting to know what others are doing, and it might be interesting to inform future research and where we need to do additional work, or even inform, I think, educational programs too.
Yeah, I mean, I think the big education that you could take from this, because like you said, this is expert opinion. Nothing in this study tells you whether or not it is okay to do it or not okay to do it. But I was surprised by the pregnancy number. For instance, over a third of people said they would never use it in pregnancy. And that to me seems a little extreme given what the evidence is. Now, I will say on the other hand, almost 17% said they frequently use it. About a quarter of people sometimes use it. So it's not like no one was saying that they used it in pregnancy, but we were down to basically 50% of people saying they would rarely or never use triptans in pregnancy, which would put a large number in my opinion.
Yeah, absolutely. Especially now that we do have some studies and definitely some registry data, and
Yeah.
there may be some shifting in conversation and things that we can use to educate our patients, I think, on that topic for sure.
I agree. I think the hypertension is an interesting one as well. There, if you take sort of the category of rarely and never, it was about 70% of people. So people were really uncomfortable with the hypertension group. And again, while we don't have good evidence there, that actual contraindication came just purely from old studies back in the 1990s because they saw vasoconstriction in cats. It's not that we've specifically studied and shown that blood pressure actually is increased or that you have bad things happen in the setting of increased blood pressure and triptans. So actually, if you review the literature, there's no consistency there. And sometimes they've even seen lowering of blood pressure. So I think it's very interesting. And again, an area that should not tell you that you can use it, but we do need to study that topic.
So what next? I mean, this is really, I think, interesting data that you've been able to find, especially from our AHS members. So what should we do with this data that you found?
I think it's really meant to open that conversation and demonstrate the gaps that we have in the literature. I do want to, follow this up with a narrative review on each of these topics to try to really delve into what does the literature say, or is there any literature? Are we completely, treating blind based on this? So again, we can just start to have the conversation and say, you know what, there is no literature, for instance, on triptans in, dissection. And actually from my review of the literature and starting to go through things, I couldn't find any good studies, so maybe a couple case reviews. So, we have 2 case reports of people who had triptans and, a dissection. But was it that they were just trying to treat a triptan because they had a dissection that was causing headache and they have a history of migraine, or is there something driving that? My guess is it's just they used a triptan for a headache that was from a dissection. So that is literally all the evidence we have on that topic. So that's not enough to actually tell us what to do. So my hope is then, all those people looking for projects, that's maybe a good next step.
Yeah, absolutely. I mean, we already feel like there is a substantial number of people who have migraine who are limited in their treatment options. And if there's a way that we can help those individuals by clarifying whether their contraindications are real contraindications or not, that's a really important thing that we can do.
Absolutely. I mean, my passion is those refractory patients. And so of course, those patients often come with a lot of comorbidities, and you want to make sure you're being safe treating around them, but you also have to start to look at the evidence and say, is not using this truly supported? Like, what is the risk benefit of doing this, and being able to have that discussion with the patient? And so let's say I've got someone who's got a history of a dissection, it looks chronic on imaging, they've been through the GPANs, they've had, lasmiditan, they've tried the NSAIDs, they're struggling. Can I try a triptan? And we don't know.
Well, thank you so much for talking to me. I think this is really interesting, and we look forward to these next research projects that you have planned.
Absolutely. Well, thank you so much for having me. And yeah, I'm excited to see what people think and get more opinions from people and see if they're surprised by the results as well.